and take.
Hi there. Good morning. Hello, everyone. Thanks, Adam. My name is Vanessa Rameh. I'm one of the attendings at Boston Children's Hospital. And I'm going to be talking today about pediatric brain tumors, what's new. So let's get started. Let me share. Hopefully you guys can see. Yeah. Okay, so today we will focus on the WHO CNS 2021 major updates. Mostly about we will be talking about imaging features of all these newly described tumor types and to revisit some of the reclassified entities and hopefully become familiar with some of the molecular terminology. So as we all know that the classification scheme in the 2016 edition of the WHO emphasized on the mechanisms through which all these molecular changes really affect the characteristics of the CNS tumors. And this was expounded in the WHO CNS 5, which was published in the 2021. And the reason of this emphasis is basically these molecular genetic diagnoses are superior in terms of tumor classification and just to correlate with all the prognosis. And obviously the limitation of the morphologic classification was acknowledged in the 2016, but just another factor is that all the morphology-based diagnoses are more subjective than the more objective way of the diagnosing these tumors, which is basically just the specific molecules and genetic changes. And the more we do all these the more we know all these molecular genetic changes, and the more we have the continued discovery of all these pathologically relevant markers. And that's why all these can basically alter the tumor biology, the clinical course, and all of this has led to the recognition of 22 new tumor types, as well as 3 provisional entities, which all these 3 provisional entities were included in the 2021 classification. But we have to wait till additional studies before obviously full acceptance. So why it's important for all of us to know this? Just because we participate in all these multidisciplinary meetings, we are a very important and integral part of all these decision makings. So just as a quick introduction, we all know that the most common pediatric brain tumors are the most common solid tumors. They are the leading cause of pediatric cancer-related death, and this number, the overall survival is basically just 1 year approximately, and this figure has remained unmoved for decades. This is just the latest, the registry for the incidence and the mortality rates, and we can see here that the incidence obviously is high, but for these age groups, and it's the #1 cancer-related death. So as far as knowledge trends, we have all these molecular techniques have refined our understanding of these pediatric brain tumors, and now we know that the pediatric gliomas differ very much from their adult counterparts. All these molecular profiling studies that basically carried out over the last 6 to 7 years have incrementally identified all these key genetic and epigenetic differences. And that's why we have all these new refined understanding of these pediatric brain tumors, which are basically distinct in ages of onset, anatomical distribution, the clinical outcome, even the radiological features. And the more we have all these advanced MR techniques, the more we know better, and we can hopefully correlate between the advanced radiophenotypes and the tumor molecular biology. So really the future is now. So imagine you're like sitting at your workstation and you have to read like a pediatric brain tumor case, and you click on the study and you can boom, predict the molecular subtypes of this tumor, and just because of all these AI and radiogenomic features. So this will probably be feasible soon. So today we're going to be focusing more about the gliomas. These are all the tumor families according to the 2021 5th edition, and you can see 12 chapters, including the metastatic diseases. And each chapter encompasses multiple tumor types. they will be grouped into families. But today we will be focusing on gliomas, glioneuronal and neuronal tumors. And as you see here, in the new classification, we have the pediatric type diffuse low-grade glioma, pediatric type diffuse high-grade glioma, the circumscribed astrocytic gliomas, as well the glioneuronal and neuronal tumors. So hopefully today we will focus on the new changes that happened in the glioma group. So this is basically all of this is the new changes or the refined nomenclature that's happened. If we want to just focus on the first category, which we're going to discuss basically now, is the pediatric type diffuse high-grade gliomas. And you can see, for example, the diffuse midline glioma, which was previously named as DIPG, and afterwards diffuse midline glioma, H3K27 mutant, and now it's named H3K27 altered. So there's this refined nomenclature. And then I'm going to talk about all of these new subtypes today. So let's move forward. Other big picture changes, obviously there's increased emphasis on all these molecular diagnostics. So now there's, in the WHO criteria, there's this essential and desirable criteria to diagnose the tumors. And then radiology is still not as strongly present in the WHO 2021, in the new WHO classification. Hopefully we will be seeing more radiology in the future, but the role of imaging is still very, very important. The other change is the tumor grading, and we all know that the tumor grading is now, the numbers were changed to Arabic numerals instead of the Roman nomenclature and numerals, and now we described the tumor grading within the subtype. So let's start with the first category, which is the diffuse pediatric type diffuse high-grade glioma. The first tumor that we're going to discuss is the diffuse midline glioma H3K27 altered. So let's start with the warm-up case. So here you see this patient presenting. He's a 5-year-old, a 21-year-old presenting with seizures. Generalized tonic-clonic seizures. So as you can see here, there's these expansile thalamic tumors bilaterally involving the basal ganglia, even here on the left side. And you can see here, there's no decreased diffusivity, maybe some facilitated diffusion. There's no enhancement. So maybe we can go farther than that. Maybe we can suggest what molecular signature it is. And the familiarity with this entity is really important. So this tumor, when we know what the tumor looks like based on the molecular features, so this tumor will be likely the DMG, diffuse midline glioma EGFR altered, which is a pediatric bithalamic glioma. Usually they have this distinct epigenetic signature, which is the frequent EGFR insertions. And this is very important because when we know it's an EGFR alter, then probably there's a potential sensitivity to these targeted kinase inhibitor. So this tumor turned out to be, on histology, it was a low grade, and then given the presence of this EGFR mutation that was found on next generation sequencing, the diagnosis is DMG H3K27 altered under this new category. Another case of a 5-year-old presenting with a generalized tonic-clonic seizures, and we see here this imaging appearance of expansile tumor in the pons engulfing the basilar artery. It's basically involving all the pons. It doesn't show any decreased diffusivity here. Basically, there's facilitated diffusion. There's no enhancement. So basically, this is a very typical appearance of what is known of DMG H3K27 mutant. The only thing that I will draw your attention to here is this presence of T2 stripes, T2 hypointense stripes in the pons, which will make sense later on. I'm gonna move forward. So this is just a big scheme on how the changes were how, for example, DIPG was not included up until DMG was not recognized up until the 2016 classification. It was recognized under the diffuse astrocytic and oligodendroglial tumors, and then in the 2021, it's recognized under the pediatric type diffuse high-grade glioma. So as I said, this is a very complex and clinical and biological landscape behind this neatly defined tumors. So in diffuse midline glioma, we can have the H3.3 K27 mutant, the H3.1 K27 mutant, or the H3 wild type, and which is basically there's no mutation on them in the histone, or the EGFR mutant, which we saw a case earlier on. So let's see here. So yeah, these are basically, as I said, this entity was introduced in the 2016 WHO classification. As I said, it's usually an infiltrative midline tumor harboring this K27 mutation, usually in either H3.1 or H3.3. And obviously, we have more and more tumor-defining molecular features, which will only going to increase in the future. And these EGFR altered tumors basically arise in the children in the midline structure, as we saw in our case, and it's always indicative of a CNS WHO grade 4 tumor. Usually when there is loss of the H3K27 methylation at immunohistochemistry, this is usually indicative of a poor prognosis. So remember the T2 stripes, a T2 hypointense signal that was seen in the pontine fibers. This is the only imaging feature that is associated with the histone status, with the histone mutation usually that is found. So this is the only MR imaging feature that is described that is associated with the histone mutation. All the other features are just can correlate with some changes in overall survival. So we know that there are certain MR imaging features that can indicate worse prognosis. For example, the lower mean ADC histogram values indicate shorter survival. If we have lower choline over creatinine ratio on the MR spectroscopy, or even if we have increased FDG uptake on the PET-CT. And we know that these two different histone isoforms, the H3.3, H3.1, they result in different, they have different tumoral behavior, different clinical prognosis, and that's why important maybe to try to separate these on imaging if we can. This is from a study that we did just to see if there's any differences in the overall survival changes on mutation. And you can see here there's definitely changes in the overall survival based on which mutation it is. So if it's an H3.1 or H3.3. The other thing that can alter is if it's a wild type or all the other histone mutation. And what we found is that if it's a wild type mutant histone, it's the tumor has a better overall survival compared to all the other histone mutations. And we started thinking, well, is there anything else that we can predict on imaging? So what we did is these ADC histogram measures, and we tried to correlate between, we tried to compare between these two histone mutations, and what we found is statistical significance between these two histone mutations when we did the parameters of the ADC histograms. And just quickly to show you, if you look at these ADC histogram parameters, the mean, the median, the modes, there are different between this patient who had this H3.3 mutation and this patient, for example, who had the H3.1 mutation. You can see here the differences in the parameters. So we can actually see differences in the tumoral enhancing component and the ADC histogram parameters between the histone mutations and the IPG. Another case of a 15-year-old presenting with visual field defect just along the same lines. This is a midline tumor, right? And it has, but this tumor has a lot of calcifications, right? So a lot of calcification in this right thalamic tumor. It's extending here to the third ventricle. There are some intrinsic T1 signal from the calcification, but there is some enhancements along its posterior aspect. So enhancing, it does look like it's low grade or like at least not high grade. There's no transependymal or periventricular T2 prolongation. So we started thinking, well, what is the differential for this tumor? What can we predict from that? So it's a midline tumor, right? So then they did the H3K27M mutation. It was positive, and then just because it's calcified, the FGFR mutation was positive too. So this patient has also like a double mutation. So taken together, the histologic features with the combination of the H3K27 mutation raised the possibility of this MAP kinase pathway mutation added to it. So that's why we're now looking, if you see any calcifications, maybe we should think of these MAP kinase pathway mutations that are associated with the H3K27 mutation. So I started looking at the literature, and this is a recent paper that was published in February 2024, and you can see here, this is a regular, a straightforward kind of DMG, right? Diffuse midline glioma. You can see maybe some T2 hypointense pontine fibers here. So this is an H3.3K27M mutant. But then this is another case that they show. This case also looks like a DMG, but this case has a calcification, and this patient was not treated. So this was found to be the H3.3 plus this BRAF V600E mutation, which is part of the MAP kinase pathway. The other tumor that is also similar to our tumor that we saw here is this tumor in the right thalamus. It also has some calcifications within it, and it was a midline, so the H3.3K27M that they did was positive on immunohistochemistry, but also this patient had this FGFR1 mutation, so another MAP kinase mutation. So maybe this is a new subtype of diffuse midline glioma, which is like a BH3K27 and BRAF/FGFR co-altered, and this has its own clinical, radiological, and its radiologic histomolecular characterization. This is just a quick overview of the MAP kinase signaling pathway. So it's really a very complex biological and clinical picture behind this uniquely unifying diagnosis. Although the WHO gives us a clear and net definition of the pediatric DMVs, H3K27 altered, there are many studies that now demonstrated the heterogeneity within this unique entity, both from a biological standpoint or a clinical standpoint. And that's why usually we know that the presence of H3K27M mutation works as an independent negative prognostic marker in DMG, but there are other variables like the anatomy, the age, the presence of BRAF co-mutations, the other concomitant molecular alteration, and all these may differ, can help us in the clinical and stratify the patient, and leading maybe to as I said, stratification of the patients according to different risk factors. So this is kind of a quick overview on the news and new things that we see in the H3K27 altered DMG. The next tumor type would be in this diffuse high-grade gliomas is the diffuse hemispheric glioma H3G34 mutant. So this is a case of a 17-year-old man, newly presenting with the seizures as well. So you can see here, this is a very, it looks like a high-grade tumor. It is involving the hemisphere, maybe cortex and subcortical deep white matter here. There is a more well-defined component with surrounding it some infiltration, ill-defined infiltration, which also looks tumoral. And you see here this, there is definite meningeal, leptomeningeal contact here, right? So on the diffusion, there is decreased diffusivity. So this is more indicative of high grade, especially here in the well-defined portion of the tumor. There is minimal enhancement. So this turned out to be an H3G34 mutant tumor. And let me show you more examples, and then we can talk more about it. This is another example of an 18-year-old male presenting with the history of paresthesias and weakness. And we can see here kind of the same theme. So well-defined mass in the hemisphere supratentorially. Here it's involving more like deep and periventricular white matter. It does have an ependymal, maybe an ependymal contact here. It does show decreased diffusivity. There is a well-defined component, and there is adjacent more infiltrative, less defined component, and it does look like it's a high grade. So this was also proved to be H3G34 mutant hemispheric glioma. So these tumors are hemispheric, as we see. They're usually supratentorial and non-midline, as we saw in these two cases. Midline extension can sometimes be seen, but usually it's an extension of the non-midline based lesion. There is a lot of variability in imaging features, but there is most frequently we can see a well-defined expansile or even lesion with this infiltrative tumoral signal. From the literature, they found that all these cases will have either ependymal or leptomeningeal contact. The enhancement doesn't help us, can be basically minimally enhancing or non-enhancing, or maybe mostly enhancing, and usually they harbor a lot of regions of decreased diffusivity. So this is a short-term follow-up, and obviously we can see after radiation, we can see this florid enlargement of the lesion. So as I said, it's a new tumor type that was identified in the WHO 2021. It's an aggressive and infiltrative tumor. Usually the age is more older children and young adults. And it is a high-grade WHO grade 4. H3G34 basically is indicative of this missense somatic mutation at the position 34 of the histone H3.3 protein. And as all pediatric tumors, IDH mutation is usually very rarely or never present in this case, for example. This is another this group studied the presence, just the characteristic and neuroimaging features of this tumor type. And what they found is that all these tumors have contact with leptomeninges and ependyma, as I showed you, and the overall survival is really not great. They also found that the overall survival is better if the tumor is well defined compared to the ill-defined nature of the tumor. So if you see like an ill-defined or well-defined mass in the supratentorial, hemispheric, high grade, have ependymal / leptomeningeal contact, it can have some hemorrhage. We should think about this tumor, especially in a young adult. The third tumoral category is the pediatric diffuse type high-grade glioma, H3 wild type and IDH wild type. This is another example of kind of similar to the prior case. It's more like an ill-defined mass. It does have some areas of decreased diffusivity, indicative of more high-grade feature. And you can see here the expansion and basically going more not only confined to this region. There's also high increased perfusion on the ASL. So it does look like also a hemispheric high grade lesion. Another case of the similar category. This is a case of H3 IDH wild type and H3 wild type, but with an RTK1 alteration. You can see here as well hemorrhage, a lot of heterogeneity, high-grade features, and minimal enhancement here. And this is also indicative of a high grade. Usually, it's very hard to separate between these two high grade tumors. But also, as I said, it's a newly described. We have lacking of the H3 and IDH mutations. It has high-grade histologic features, and we have 3 molecular subgroups that really differ in important ways. And maybe in the new, in the future WHO classification, we will be seeing more separation of these entities, and these are the key molecular features that were noted. And also, the pediatric radiation-induced gliomas are always, according to the literature, are always H3 wild types and IDH wild types. So maybe if we see a radiation-induced high-grade lesion in the supratentorial brain, maybe we should suggest this diagnosis. The fourth tumor type is this infant type hemispheric glioma. This is also a newly described entity in the WHO 2021. This is a case of an 8-month-old presenting with new focal seizures. So the age is key. The appearance is also key. So we see here a solid and cystic, mostly solid, but we have some cystic areas. And the bifrontal region, we have some decreased diffusivity. We have a lot of hemorrhage on the SWI, some heterogeneous calcification and heterogeneous enhancement and intense calcification. A note here that the cystic walls here have some enhancement. And compare and contrast to this other case, this is a 9-month-old patient presenting with increasing head circumference and irritability. And we see here kind of similar cystic solid appearance, but with some hemorrhage within the solid component, some enhancement. But look at the walls of the cysts. The walls of the cysts are non-enhancing compared to the walls of the cyst of the other infant hemispheric glioma case. And then we see here this kind of it's more displacement of the parenchyma rather than just invasion and involving of the contralateral side. And then I don't have the diffusion here, but the T2 signal is slightly different than this T2 signal that we saw here. So it has less decreased diffusivity, no enhancement of the walls of the cysts, and more like mass effect rather than invasion of the adjacent parenchyma. So this is a case of DIG or DIA, desmoplastic infantile astrocytoma. They both have very similar imaging features. They both can occur in infants, usually less than 1 year of age, up to 1.5 years of age. But the differences are, as I said, the decreased diffusivity, the enhancement of the walls and the walls of the cysts, and the invasion of the brain parenchyma. They both can look very aggressive, and they both have hemorrhages. So these are some of the clues that can help us differentiate them. So just as a quick thing, there's usually the infant type hemispheric gliomas are seen in the first year of life. They're large supratentorial masses. No definite CNS WHO grade yet. Maybe we will see that in the subsequent classifications. Usually they have characteristic receptor tyrosine kinase fusions, and this is important for the treatment. And these are the abnormalities, usually the anti-RK family, as in this case. It was an anti-RK fusion positive. And some of these patients will have leptomeningeal dissemination. So usually spine screening is advised either after treatment or at diagnosis and after treatment. So these are all the newly described changes in the pediatric type diffuse high-grade gliomas. So let's move on to talk about the pediatric type diffuse low-grade gliomas. There are these 4. Not all of them are new. There are some changes within some of them. So we're going to talk first about this diffuse astrocytoma MYB and MYBL1 altered. And this is also kind of here. It's another oncogene. We're not going to go into detail into a lot of details now, just because of the it needs another 1 hour. But let's look at this example. So it's an ill-defined tumor. It's located as expansile. There's T2 prolongation. It's located in the superior, in the temporal lobe here on the right side. We notice some cystic changes within it. And we see some, we don't see any decreased diffusivity. It's mostly facilitated diffusion. We don't see any enhancement. I don't have the flare here, but the flare in this case showed the T2 flare mismatch, where we don't see, we see kind of the suppression of like homogeneous or inhomogeneous suppression of the flare signal. And this is described in the tumor, in this tumor type. This tumor type can occur supratentorially or infratentorially. This is another case. It's centered in the vermis. We can see here this T2 prolongation lesion with some cystic changes. There's no decreased diffusivity and no enhancement. And this is indicative of a low-grade lesion. In this case, when you see cystic changes, if we have the T2 flare mismatch sign, we should probably suggest this diagnosis. It's rare, and it's usually a WHO grade 1. The age is usually 5 years as a median age, and usually seizures, and specifically long-standing seizures, is the most common presenting etiology. And all of these low-grade gliomas are usually H3 and IDH wild types, so there's no mutations in the IDH or H3 genes. Another case, more like cases from the literature, just as a clinical pathological correlation and even radiological correlation with these MYB and MYBL1 altered tumors. This is the group from St. Jude, and what they described is when they see this lobulated appearance in the supratentorial brain. Even here, they said it's more ill-defined when it's involving the midline structures or even the infratentorial brain. But what they concluded is this lobulated appearance, this T2 difference in T2 signal, is also one of the features that is seen in this in the MYB altered tumors. The other tumor type is this diffuse low-grade glioma MAP kinase pathway altered. This is also a newly recognized tumor type that was also added in the 2021 classification. I don't have a case of cortical one, but this is a case from the literature where it's basically similar to the other one that we saw, like along the midline, but this one is involved cortex and subcortical white matter. It does look like it's more like a low grade, I think what they said, and it does have a lot of classifications. So when we see classifications in a supratentorial appearing low grade, sometimes the diffusion is hard to interpret in the ADC when we have a lot of classifications. But we can probably suggest this diagnosis of MAP kinase altered. And what they said too is the presence of, usually there is some heterogeneous enhancement on the as similar to the case that I showed you like earlier. There is calcification, but we can depict some heterogeneous enhancement within the lesion. This is just because sometimes it's very hard to differentiate it from the plenty, which can calcify, can have these coarse calcifications, and plenty does have the MAP kinase alteration, but usually classically the plenty tumors do not enhance, or maybe very minimally enhance. Usually the calcification, when we see calcification in these cortical tumors, they kind of in a way are similar to oligodendrogliomas. So they do have oligodendroglial morphologic characteristics on histology. The FGFR, specifically the ones that have FGFR1 mutations or alterations, usually have these calcifications when we see the MAP kinase pathway altered gliomas. The WHO has not assigned a grade yet for this tumor, just because it's very heterogeneous. There's a lot of molecular alterations, but maybe in the future when we have more data, that will be more well defined. So we're done with the pediatric types, diffuse high-grade and low-grade gliomas, and we're going to focus now about on the circumscribed astrocytic gliomas. So the only changes that has made this to astroblastoma MN1 altered. It's not a newly recognized tumor, but it has been refined. They also added this high-grade astrocytoma with pyeloid features, but we're not going to talk about this today just because it's more in adults rather than in the pediatric population. So just as an example of an astroblastoma, this is a case where we have a subcortical-based tumor. We have T2 kind of isointense to cortex or maybe hypointense. It does look like it's more like a high grade with this decreased diffusivity. There's a lot of edema and some enhancement, and a lot of edema, vasogenic kind of edema surrounding it. You can see here this like kind of bubbly appearance, which is more described in the astroblastoma. We can see another case here. It's kind of similar solid cystic with some hemorrhage, some calcifications and enhancement. It does have some surrounding edema, and this was also turned out to be an astroblastoma. So this is very hard to differentiate from ependymoma. Maybe the age can help us, but in ependymomas, usually we kind of see the same thing. So this is a case of ependymoma, and it's very similar. So we see cystic, solid appearing mass involving the cortex and subcortical white matter. We see some calcifications. We see some edema surrounding it here. And some enhancements. There is this rule that we always talk about is the 1, 2, 3, 4 rule for the supratentorial ependymomas, which stands for, so 1 is for the single large tumor common in the first decade. 2 is for P, so perilesional edema, the periwinkle sign, which we're going to talk about later. 3 is for the large lobulated lobar mass, and 4 is for the central chunky calcification and the large peripheral cyst. So basically just as a descriptive rule to help us kind of differentiate between ependymomas, intraparenchymal supratentorial ependymomas from other supratentorial tumors. Sometimes it's very hard and it can be tricky, but if we see these findings, maybe we can think about ependymoma. This is the periwinkle sign that I was talking about. So we have, when we see it, it's described on CT. When we see it, the literature says it's classic for ependymoma. So centrally, there's this necrosis, which is the central part of the flower. Peripherally, there's the centripetal calcifications, which are the petals of the flowers. And the peritumoral cysts, which are the leaves of the flower. Sometimes it can work, sometimes not. So just as a quick overview, as I said, the astroblastoma is redefined in the 2021 classification. It has a characteristic morphology on pathology, and there's this MN1 alteration, which they added to the nomenclature. It's supratentorial and peripheral, and there's no CNSWHO grade yet assigned, just because I think it's just heterogeneous. It can be low grade, it can be high grade with aggressive features, and the high grades can recur. Overall, this tumor has a favorable overall survival. The last category, I'm not sure if Adam, I still have some time. I can talk a little bit of the glioneuronal and neuronal tumors if you guys are okay.
Yeah, go for it.
Okay. So the last category for today would be the glioneuronal and neuronal tumors. In this category, we have some new entities, including the myxoid glioneuronal tumor types, the diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters, which I call it DGONG, and the multinodular and vacuolating neuronal tumor, which is the MVNT. Just as a quick overview, we know that this is a schematic of the neuroepithelial cell, which is the neural stem differentiation, and it can differentiate into the neural progenitor and the glial progenitor. So when we have a neuroglial tumor, basically we have these two progenitors, and even the tumor can originate from the neural stem cell. There are two subgroups in the glioneuronal and neuronal tumors according to their molecular characteristics. So as a broad groups, we can talk about the astrocytic predominant and BRAF mutant tumors, or the FGFR mutant, which basically are the pattern 2, where there's more like oligodendroglial cell predominant kind of pattern. And this is more with like FGFR mutation rather than the BRAF mutation. This group of tumors share some clinical, molecular, and imaging features, specifically the children's with epilepsy. They're mostly children and young adults with the long-standing seizures and epilepsy. Usually they have good prognosis on surgical resection if we can do the surgical resection. And molecularly, they have some common features, including the MAP kinase alterations. On imaging, they can have some features that are common. Let's start with this first entity, which is the MVNT. This entity is usually we should be aware of it just to avoid under or misdiagnose it. This is an 18-year-old patient presenting with seizures, and we can see here this cluster of mostly subcortical cystic changes, like cystic bubbly kind of tumors. It doesn't suppress on the flare, and usually the cyst side, it may resemble DNET, but the cystic size is usually less than, they're smaller compared to DNET. And usually DNET has this more perivascular like prolongation, versus here is like more like focal rather than having this perivascular appearance. So this is an MVNT case, which is usually it's not so new. It was introduced as a provisional entity, but now it's approved. And as I said, usually patients present with seizures, and it's a low-grade lesion with a grade 1 type. Another case of myxoid glioneuronal tumor. This is also a newly described entity. It's a low-grade. It's usually it was called the DNET-like neoplasm of the septum pellucidum. And as you can see here, this is a very well-defined lesion, no enhancement, no decreased diffusivity, and has tissue prolongation attached to the septum pellucidum. So when we see this appearance, it's basically diagnostic of this myxoid glioneuronal tumor type. The age at presentation can be very variable. And usually its signature molecular feature is this PDGFRA that we usually see. The last group is Digong. This is basically a very newly described entity. We don't have a case yet. This is a study from the literature that's basically show kind of some of the features of this tumor. So they say that we have this central T2 hypointensities, which can correlate with some calcifications. For example, here it doesn't look so aggressive. It does look like it's surrounding the circular ofilus arteries here, but it doesn't compress them. It just kind of encases all of them, but with no like obstruction or mass effect or anything. And what they describe too is the peritumoral T2 prolongation as well. They also describe the sign, which is the faint linear enhancement, which I think is still non-specific. So I think we have a lot of we will be learning about this tumor more in the future. And also it was only included in the WHO 2021 as a provisional tumor type. It's usually identified just because of its methylation profile. The mean age usually 9 years, and it's known to have a favorable prognosis. But as I said, there's not a lot in the literature about it. So finally, tumor classification in the reading room. So as discussed, many CNS tumors can demonstrate the characteristic imaging findings, and some findings specifically reflect molecular tumoral diagnoses. And molecular techniques are basically enhancing our understanding of brain tumor pathology more quickly than ever. And all these fast advancement require us, the radiologists, to just stay up to date with all these neuro-oncologic developments. And we really add a significant value, and we play a crucial role in the care of the patients with tumor imaging, making it vital for us to stay current with all the advances in the field. We help differentiate tumors from tumor mimics. We help detailing the anatomic considerations, which are very important for surgical planning. We provide preliminary information about suspected tumor abnormalities, and we can be a very important part in the various treatment strategies. So thank you, everyone. I think that was it for today. I have another part 2, but we can I think we can do that later. Thank you so much.
Sounds great. Thank you so much. That was wonderful. Very, very detailed, and it's definitely a very confusing topic, and this definitely helps elucidate some of these entities. And we'll definitely have to have you back for the second part of that. The question going, as we kind of learn more about these and we can differentiate them, and as imaging features kind of become more specific, we think, for certain molecular features. Going back to when you were talking about in the reading room, how specific do you think we should be when we're actually reading these cases? Should we be trying to make specific molecular diagnoses? I mean, most of these are gonna get either biopsied or taken out anyways. Should we wait for AI to kind of give a probability of different molecular features? Or guess so from a reporting perspective, and how specific do you think we should be kind of with these diagnoses?
Yeah, I mean, I think I'm kind of biased. I think we should be more and more specific, because the more we try to look at all these cases and try to come up with the molecular and all of the signature, I think we will learn more, and we can teach more how to basically approach these cases. And just as an example, when you're in tumor boards and you're discussing these cases with the clinicians and with the oncologists, they this is their language. So I think it's very important to just try. I know we have a lot to go, and maybe a long way, but I think we should try as best as possible, just to speak the same language as all the other clinicians and be helpful.
Yes, definitely. So we have a couple comments. Susan Palacios says, "Thank you for your comprehensive talk. Tough subject for us."
Thank you.
I'll do that. Yeah, Fernando Torres says, "That was amazing. Thank you." A comment from Bland Aslan. "I believe the DWI is the most helpful sequence in peds brain tumors, in addition to location."
Agree. Yep. Agree. We shouldn't be, as you probably all know, we shouldn't be looking at the enhancement.
Okay. Any other comments or questions? Feel free to put them in the chat.
Well, if you remember any questions later on, you can email me. I'm just gonna put my email in the chat. Feel free to reach out, or if you have any ideas how to improve our brain tumor understanding, that would be helpful.
We have a question about how often do you use MR perfusion for tumors?
We usually do it on all the tumor cases, the newly diagnosed tumor cases. But I do believe that all the conventional sequences are really helpful, rather than just go and look at all the advanced methods.
Yeah, agreed. Yeah, I think especially for all, as all these all these entities are so rare, and especially as these tumors are so kind of subclassified and split by these kind of rare mutations. I think having great collaborations and working together to better understand, look at imaging features and, you know, outcomes is you know, becoming really important with these tumors. So yeah, so definitely we're always interested in collaborations.
Sure.
Any other questions? What about how about spectroscopy? Do you do spectroscopy?
Yes, yeah, it's part of our protocol for the newly diagnosed brain tumors.
Any other questions? Thank you so much for this wonderful talk. And we'll put it up on YouTube if anybody missed it. And have a great rest of the month. And hopefully we'll see you guys next month.
Thank you all so much. Bye bye. Thanks, Adam.